So I want to talk about prophylaxis. Now, my thing about prophylaxis is I'm going to specifically talk about prophylaxis during long hospitalization, so nosocomial diseases. And so my thing about prophylaxis is most of it's behavioral, and whenever people bring it up, everyone's thinking medication, but it's mostly behavioral. Like, what's the best prophylaxis for a venereal disease? You guessed it right. And so when I was looking into this, what I found was there's probably a million different reasons to use prophylaxis, but we're going to go over the most common really quick. So the main thing, especially in a hospital visit, is preventing venous thromboembolism, or you could say deep vein thrombosis or pulmonary embolism. So those are the main thing, the main venous thromboembolisms. So also you're going to use it pre-surgically a lot of times, depending on the type of surgery. And just for example, if a person is going to go through a colon surgery, they want to give that person neomycin and erythromycin every day for a certain number of days before that surgery, and that kind of is done to prevent the intestinal flora from getting in and causing you to be septic. In specific cases of diseases that are high risk in various patients, prophylaxis is used to prevent those infections. So in our specific case, the guy is um, he has had a previous C. diff infection, so he's prone to that. And so, in what cases would we want to use prophylaxis in that treatment? Immunocompromised people are often given various prophylactics if they're in the hospital or if they have a very, very low white count. And in all these cases, the CDC has a set of guidelines for hospital-acquired infections, and so I'll give you that link at the end. So what is a venous thromboembolism? So basically we get where there's no movement of blood going. Whenever your muscles contract, it kind of pushes the blood up through these little these valves. And whenever you're laying down for a long period of time, you're not pushing the blood up through the valves, and so you can get clots forming in the veins, especially in the deep veins where the muscle compression is the most important. And when it happens, you can see that it will build up an edema on the legs, and whenever the clots break free, an embolism will go into the right atrium, right ventricle, and then into the lungs. So you get blocks in your lungs. It prevents blood flow in the lungs, and it reduces the oxygenation, so the perfusion ventilation ratio changes. And pulmonary embolism is a large risk for death. So you get a pulmonary embolism, you have a high risk of dying from it. Now, there's a little bit on here about epidemiology. There's a lot more epidemiology on deep vein thrombosis and pulmonary embolisms, but I'm not really that interested in it, so I'm not going to cover a whole lot of it. But just know that it's a big deal. That's the point of the epidemiology, is that DVTs are a big deal. Anyhow, so the risks. There's a lot more risks, so this is just a few of the risks. One of the biggest risks is that you've had a previous thromboembolism, so a venous DVT, PE. If you've had one of those before, that is a high risk, and there's actually a risk. So there's several different places that create these risk score assessments, and on those assessments, previous DVT puts you at like a 5 already, and so the highest you can go is 11. And so just think about previous DVT puts you at a 5, so you're already halfway at the max. But some other things, like if you're stuck in a hospital and not moving, or any period of not moving for greater than 24 hours, if you have major illnesses to different organs in your body, that increases your risk as well. And then post-op, they want to get you up and moving really early, because if they do, it decreases your risk of developing a pulmonary embolism. Like I said, this is only a partial list. If you want a full list, you got to go to the study guide. But there's something on the study guide I actually wanted to point out, and that was I have on here that transdermal contraceptions. Something else is hormone replacement, and under hormone replacement on study guide, I have tamoxifen. And if you know what tamoxifen is, it's an estrogen analog antagonist. And so what that is it binds to the estrogen receptors on the breast and prevents estrogen from hitting that. And it's used by it's used to treat some types of breast cancer, not all of them, but some types of breast cancer are treated with tamoxifen. Another thing is that weightlifters will use it after using anabolic steroids. I know this because there was a time in my life where I was interested in anabolic steroids. Now, anyone who's ever seen me knows I've never used them, but so one thing I found in the research when I was looking into this was that tamoxifen is used by weightlifters after their anabolic steroids to prevent gynecomastia. And so just know you get a huge dude with giant forearms and giant biceps, and he has a deep vein thrombosis, or he appears to maybe have some edema in his legs. Maybe you can think pulmonary embolism or DVT. So there's a lot of risk calculators for VTEs. I like this one really because it takes four things into account and it gives you a score. So you just plug in four different risk factors, but you got to realize there's more than just four risk factors. It's just that this one simplifies things. So what is the prophylaxis for a VTE? So there's pharmacological, there's mechanical compression, there's behavioral changes. So one of the behavioral changes, for example, get people up and walking right after they wake up from a surgery. The mechanical compression, if a person has to be laying down for a long time, what happens is they put these wraps on your leg, and these wraps will do like a peristaltic compression. I say peristaltic because I've been thinking about the GI tract all day. But so it starts the compression here and it increases it in this direction to kind of force the blood through. And they can make these for the feet, they can make them for the calf, they can make them for the thigh. And the biggest problem with these is patient compliance. For some reason, patients just don't like things pressing their leg all the time. And I mean, I can understand, but if it's going to save my life, I'm going to wear it. So other things, lower extremity exercises, graded compression elastic stockings. These are just things I found that are for sale to prevent VTEs. This continuous passive motion. There's also a thing where you can place a filter inside of large veins. So one of like the femoral vein or the inferior vena cava, and if an embolism, if a clot breaks free, it will be caught by this mesh and prevent it from going to the lungs. I don't know what studies have been done on this to see how safe it is, to what happens if multiple emboli come up here and clot the whole vena cava, or if that's even possible. So, I mean, that's just something that you could look into if you're interested, but this exists. It's amazing to me. So everyone knows that there's anticoagulants you can take to help prevent VTEs. And the one thing that was amazing, it's really hard to find what the contraindications are for anticoagulants. But one of the major contraindication is an active gastroduodenal ulcer or any type of bleeding within the last 3 months or a platelet count less than 50,000. Those are the main things that keep coming up repeated over and over again. And there's some other things that you can look into, such as if a person is hemophilic, they have like a genetic hemophilia. You can also look at the ease with which someone bruises, like does someone bruise really easy, that kind of thing. Now, when someone has to go through a surgery, there's something called a Caprini score, and this score tells you how much of a risk this patient's going to be if they don't use a pharmacological anticoagulant. So you can have different things of 1, 2, 3, 4, 5 points, and what you do is you go through and you check all of these things all the way down, and you add up all the points. And if the person has a score of 5 or greater, they're at a high risk for a pulmonary embolism post-op. And so here's the rest of the list for the Caprini score, and then here's the interpretation. So if you have a very low risk is 0, and your risk of a VTE is less than 0.5, and then a low risk, and then up to high risk you have a 6% chance. That's pretty high risk. Like if there's 100 people and 6 of them are going to get a pulmonary embolism, I don't want to be in that group. With infection, oftentimes the infection will be associated with a specific thing, so a catheter, urine, intravascular, ventilator associated, surgery, bed sores, those type of things. And so for each of these, there may be a protocol for an individual hospital for a specific prophylactic measure. Usually it's going to be behavioral, so how well do you clean the urethra before you insert the catheter, or how well you wipe down the skin before you insert the intravascular catheter. So those type of things are behavioral, but there may also be pharmacological prophylaxis as well. And so like I said, most prophylaxis is behavioral, so hand washing, educating physicians, cleaning and disinfecting the room, so make sure your housekeeping staff is really up on par with the education as well, and then reviewing the local epidemiology. Now, I don't know why, but for some reason my slide got cut off on this page. There's supposed to be a lot more down here, but anyhow, I'll just go through it. So the four main standards for infectious control in a hospital are hygiene, isolation, environmental, and surveillance. Now, speaking of isolation, there was a doctor. He was walking out and he says to a fellow physician, he says, "I have a patient with AIDS, chlamydia, gonorrhea, and syphilis." The other physician friend says, "My gosh, that's horrible. What do you do for a patient like that?" And he says, "I have him on a special diet of pancake and flounders." The other physician says, "Pancake and flounders, that is genius. Does it work?" He says, "I don't know, but it's the only thing that'll fit under the door." And so anyhow, the four standards, so hygiene, always wash your hands. You wash your hands before touching a patient, after touching a patient. You wash your hands all the time. Just wash your hands for no good reason at all. Just wash your hands. That's the standard. Wash your hands. Anyhow, you got to dispose of needles. You got to use universal precautions when you're dealing with blood and bodily fluids. Wear gloves, especially when you're touching mucous membranes and stuff like that. And then wear a mask, especially if you're at risk of spreading droplet infections. So then isolation, there's different precautions for that. So there's contact precaution where if a person has a disease that will be spread on contact, you give them a private room, or you can give them a cohorted room where everyone with the same disease can be grouped together. And then there's the droplet precaution where droplets, if something spreads in droplets, it can only spread to about 6 feet. And so if you're going to be handling that patient within 6 feet, you wear a mask. Airborne precautions a little bit different. So you have to have a room with negative pressure, and anyone going in that room should have a mask on. If it's various types of diseases, even require the use of a respirator. So respirator is going to keep you from inhaling those airborne infections. On the other end of that spectrum, if a person is immunocompromised, you don't have them on a negative pressure, but you put them on a positive pressure. So you're pushing air into the room through a HEPA filter and causing the air to flow out of the room through positive pressure, and that keeps new viruses and bacteria from coming into the room and just constantly pushing stuff out. And it has to be no less than 12 air changes per hour. You also say no flowers and other stuff are allowed in the room. Now, environmental, that's basically related to like what can go into the room and what can't. Then surveillance, the last thing in infectious prophylaxis is surveillance where, and it's not the surveillance like where we got our eye on you, it's like reviewing microbiological records, it's going through autopsy reports, pathology reports, and that kind of stuff to see what is going on and is our stuff working, and is there anything we can do better. So any kind of prophylaxis can be a little bit controversial. But so C. diff, there's a lot of different studies. Some studies say take antibiotics prophylactically in this case and don't in that case, and other studies contradict it. What has been found for sure is that if you're taking an antibiotic for an infection other than C. diff, and you're at a high risk of reinfection for C. diff, so whenever you take those antibiotics, it's good to also take them with vancomycin. So if I've had a C. diff infection before, which I haven't, but if I had, let's just assume, and I get a strep throat and I need to take a Z-Pak. Well, I'm going to take that Z-Pak with vancomycin in order to prevent, it has been shown to prevent recurrences. So you have a person that's being admitted to your hospital and he's at risk of C. diff reinfection. It's going to depend on what your hospital's care plan is. So whenever you get there, if you're already there, just review whatever their specific plan is for that situation. Everyone knows CDC is the boss. So the CDC actually has guidelines for healthcare associated infections, and you can go to this link and you just go through. It's got like a bunch of information, so much information you'll be blown away. You'll be like, wow, this is prophylaxis. I cannot believe this. Now, just to kind of give you an idea of the paradigm shift in using prophylaxis, I want to give you a little short story. Because I talked to an old physician one time, and he was telling me that a kid comes in with a viral infection. Let's say he's got a viral upper respiratory infection. Let's say it's the flu. Now, I don't know if the flu works really well in this specific case, but I'm just going to use the flu. So assuming this kid has the flu, and some infections having a virus makes you predisposed to also acquiring a bacterial infection. And so you would give antibiotics prophylactically, not because it helped with the viral infection, but you would just give it to prevent other infections because your immune system's already trying to fight off one thing, and if something comes in from another angle, another attack, a backdoor attack by a bacteria, then it's a bad thing, but you can prevent that with a prophylactic antibiotic. And I'm sure at some point there was evidence, there probably still is evidence, that reduces the length of some illnesses only because it prevents the illness from being carried on by another bacteria. However, the paradigm shift is, yeah, that was great at one time, but now we're creating superbugs and we don't like that. And like I said, the CDC is the boss, and they say don't do that, so we shouldn't do that anymore. We got to quit just giving out antibiotics. It's just not a good thing. So in summary, be very judicious about what kind of pharmacological prophylactics you are willing to use.